Morning, everybody. Welcome to week 3 of spring of 2020 quarter. And this is your spinal anatomy lecture for Tuesday, week number 3. We talk about ligaments of the pelvis and lumbosacral spine, mainly, and the SI joint, I should say. And yep, here we go. So some of the key ligaments we'll be covering are the anterior and posterior sacroiliac ligaments, the interosseous sacroiliac ligament. We'll touch on that quick because we talked about that last time quite a bit. Iliolumbar ligaments. That is a very complex ligament. We'll talk about that. Superior fibers. I don't know what to do with those superior fibers because Bogduk puts out some evidence that, Bogduk is kind of the god of the lumbar spine, right? He's probably more respected than Cramer is, I believe. And he says that there are no such thing as the superior fibers, so I think we can cross that out. There's definitely inferior fibers. Time's coming. We'll get to a sacrotuberous ligament, sacrospinous ligament. So that's kind of where we're going here. Let's start with a review of probably the most important ligament of the sacroiliac joint, for sure, interosseous sacroiliac ligament. It is located posterior to the auricular surfaces. Right, it's behind it. In fact, it acts as the capsule of the sacroiliac joint, which is, remember we said the sacroiliac joint is a semi-diarthroidal joint because it doesn't have a full capsule, and it makes up that posterior surface of the SI joint. Keeps the synovial fluid in. It's some authors say it's 2-banded, but I would go with 3-banded. Cramer says 3-banded. And Bogduk says 3-banded as well. And it's believed it is the true weight-bearing structure of the sacroiliac joint. Bogduk calls it the most important ligament in the SI joint. And it's buried underneath other ligaments, so you can't see it. Here's a picture, overhead bird's eye view of it. Here's the horizontal or an axial view. Chop right through, let's say, S1 segment or the S2 segment. The sacral canal is here. And here's the SI joint. It's in the front, right? And this is the actual interosseous sacroiliac joint at this level, at this cut, is back here. What if we did a cut right through here? You wouldn't see it. It'd be gone, right? Sacroiliac is above that level. Okay, here's a coronal view, or from the front view. From the back view would be better, where they chopped off the PSISs are cut off here in the back. You can see the superior articular process of the S1 segment. Inferior articular process of L5 is right here. So there's the Z joint, zygapophyseal joint, facet joint on the right here. And so here with this type of a cut, we can see the sacroiliac, all 3 fibers of it, how they mesh together quite well. Right, functions to strongly bind the sacrum and ilium together. It kind of engages the locking mechanisms. We talked about hills and valleys last time, and how that sacrum has about 2 degrees of motion, and that's it. And what do they connect? There's 3 sacral fossa. I won't go over again. We didn't see the last video. But there's a superior, middle, and lower, inferior sacral fossa that those fibers arise from. They all connect to the tuberosity of the ilium, or iliac tuberosity. Oh, I guess I will show you them again. Here they are. So there's kind of a cartoon of them. Normally, in real life, they're all kind of morphed together like this, but they do arise out of these 3 sacral fossa, upper, middle, and lower. And we cut them away except for just the little bits of the threads where they connected. And here's the tuberosity of the iliac right here, iliac tuberosity. behind the auricular surface. Now, this artist didn't realize that there are elevated surfaces, although you can't see them that well, kind of obscure. Nevertheless, they are there. Okay, here's just another, that bird's eye view again, or that axial cut showing the actual SI joint right here. And there's the interosseous sacroiliac ligament. And here is the capsule of the sacroiliac joint. On top of that, we're going to add a new ligament that we haven't talked about. And these two ligaments are really blended together, so you can't really tell the difference. Anterior sacroiliac ligament, which isn't really that exciting. It's not really that strong. It doesn't do much weight bearing. Let's talk about it. Anterior sacroiliac ligament, sometimes just called the ventral. Remember, ventral and anterior are AKAs. Ventral sacroiliac ligament. It helps bind the sacrum and ilium together, provides very little supportive function to the SI joint, covered anteriorly by a capsule. So actually, would that be covered posteriorly? Oh, it covers the anterior articular capsule. It's about 2 millimeters thick. And yep, and the two are inextricably bound together. That's wrong. I'm still looking at that. Let me make a note of that. Fix 11. Yeah, that's wrong. So it is covered anteriorly by the it's not covered. It doesn't cover anything. It covers the anterior articular capsule anteriorly. That should be broken up into 3 components. These are all bound together. You really can't see them, but there's a superior fibers that run more superolaterally across. There's middle portion runs horizontally, and there's an inferior portion that runs more inferolaterally. And they are, importantly, they're covered by the inferior fibers of the iliolumbar ligament and the vertical fibers as well. Oh yeah, there's the vertical fibers. There it is right there. All the fibers are kind of bound together. So it's a thin ligament here. Nice view of the sacrospinous ligament here. Spine of the ischium to the sacrum. Sacrotuberous ligament. I digress. I'll get back on track. Here's another picture of them. But you can see in this artist's view, here is the incredibly complicated iliolumbar ligament. Here's the inferior fibers of the iliolumbar ligament, which only Cramer actually calls them. There's an AKA out there called the lumbosacral ligament. It's AK for the inferior fibers of the iliolumbar ligament, as we'll get to. They didn't draw another band and come straight down like this. So we'll get to that. In fact, let's get to this crazy iliolumbar ligament right now. Very complex. Authors are having trouble with this one. And that, for a good reason. That the ligament is very complex. Bogduk breaks it down into a superior, talks about it, but he goes on then and says the evidence is such that it's not really a ligament. But we'll see. There's really 4 bands. There's the anterior and posterior iliolumbar ligament. And then there's 2 downward running ones, the inferior fibers of the inferior iliolumbar ligament, and then the vertical iliolumbar ligament, which of all the ones clinically important, this is the one that's important. Some early anatomists did really good work, really meticulous dissection. They came up with this drawing of it, and it's a very complicated region. So this is the one that is controversial. And this isn't even quite drawn right because this comes from the transverse process. So it really comes like this. If we could see through some of this fascia covering, it comes like this. And the transverse process, like this. Right, here's the other transverse process. So that one's kind of like that. All right, so that one is just thought to be, here's the quadratus lumborum, and it has a fascia, an aponeurosis down here. And this is believed to actually be part of the thoracolumbar fascia now. And yeah, right above the thoracolumbar fascia for the well, let me guess, I'm getting out of control here. Let's just go through this step by step before I explain it here. All right. So but these, let's go back to this. Transverse process is still here. So we have this band running down here. So that's called the vertical iliolumbar ligament. That's important because, let's see, because we have right here, that's not a good color, how about yellow? Right here, we have the anterior ramus of the L5, M5 anterior ramus coming right here. And L4 would be coming right here to make the lumbosacral trunk. So this is clinically important because you could get bone spur development, right? As you get old, we'll see some of these ossifying, and you might get bone spur stabbing right into that member of the sciatic nerve, and it is a rare cause of sciatica. Okay, and then there's the inferior iliolumbar ligament there. Notice how both of these two cover the anterior sacroiliac ligament, which runs here. There's the fibers here, but the fibers are also, you can see them sneaking through here. We actually have one cadaver specimen who has this vertical ligament as a nice cord. You can see it quite nicely. Okay, the anterior and posterior sacroiliac ligaments are behind this stuff. So we're saying, according to Bogduk, all of this front covering is part of the thoracolumbar fascia, right? Which of course goes up, like that. Quadratus lumborum comes down and anchors into part of this fascia, but it comes down to the layout crest eventually. So quadratus lumborum is in this mix because the muscle part is done. The tendinous kind of membranous portion is adding into these tendinous structures. So very complex anatomy, area of anatomy. The other thing I'll say is that even Netter in some of the books, they always have the iliolumbar ligament coming from L4, and nobody even mentions that except for Standring. Says occasionally some anomalous connections of the anterior and posterior portion of the iliolumbar ligament could come from L4. So it's not correct to draw it coming from L4. That all comes off of L5 in most cases. So Bogduk says there's no superior iliolumbar ligament, and this is confirmed by another more modern research study. So that's another one. I just made this PowerPoint last night, so add that to my list. It's just the fascia of the quadratus lumborum. The vertical and the inferior iliolumbar ligaments are real, and they deserve that. They're real ligamentous structures. They're not part of the anterior iliolumbar ligament, as some authors believe. All right, so let's see how Bogduk describes these. So how does he describe the iliolumbar ligament? Well, here's kind of more of a fun fact, though, about the iliolumbar ligament. There is even a controversy. Some people don't even think it's a ligament. They think it's a kind of a petrified muscle, because in one study, in children, more than one study, it was actually found to be muscular. In fact, we have a cadaver specimen that it's muscular, and it's probably it's definitely an adult. So it doesn't, until the 5th decade of life, it's not when it becomes more of a pure ligamentous structure. So it's a really strange type of a thing here. And we definitely have a cadaver. I don't know if we still, I think we probably sent that one back. If not, I'll show it to you guys when we get back in school. But yeah, it's definitely a muscular structure in this specimen. And then in old people, so by the 5th decade of life, then you have your pure ligaments, and that's in the 40s. And then older people, 60s, 70s, it can become fatty and even calcified. So what is its job, though, no matter what it is, if it's muscular, ligamentous, or kind of scarred up, calcified thing? Its job is to prevent forward slip, a condition called anterior, or an action called anterior sagittal translation of the L5 on the sacrum. It also resists other motions like lateral bending, flexion, extension, rotation. But this concept of sagittal anterior translation, or you could say anterior sagittal translation, you can flip those around if you want. Could draw that concept. So let's draw L5 would be right here. There's the spinous process in the back. So this is a side view. Just make a cartoon of this. And then I think I've done this before for you, it seems. Here's the sacrum. All right. So anterior sagittal translation is just a slip forward. So it's a slip along a plane. So it's this movement here. That's anterior. And posterior would be moving back like this. So that's anterior and posterior sagittal translation. All right. And those ligaments, I mean, what would so if this was the spinous, the transverse process coming out of the plane, and that ligament is anchoring here, and I mean, I can't draw the ilium in there, but it's preventing this movement, this anterior sagittal translation. Okay. I'll talk a lot about that because that's going to be important in understanding spondylolisthesis. All right, what about the anterior lumbar ligament? So this one is there. It's well developed. It arises from the transverse process, the entire length, and it connects to the adjacent ilium. So I'll show you a picture. When we get to Cramer's interpretation of this region, I'll show you a picture. It connects adjacent to adjacent ilium. Some of the quadratus lumborum is also anchored into these fibers. So it's a kind of attachment point somewhat for that muscle. Posterior longitudinal ligament, we'll see that when we get to Cramer's stuff. It also rises more from the tip and the posterior part of because that's why it's posterior. So it rises from the posterior spinous or transverse processes. It also connects to the adjacent ilium. So we got from an overhead view. Oh gosh, do I dare try to draw this? Let's see. So overhead view. Let's say this would be the iliac crest, kind of from an overhead view. And there's the vertebral body. L5 transverse process. So the posterior sacroiliac ligament would be attached back here and come into the ilium. I guess I can kind of draw this. And then the anterior sacroiliac ligament arises from the anterior portion of the L5 transverse process and also connects in like that. So from a bird's eye view, I'll show you a better picture of this in a minute, but that's kind of what it looks like in a bird's eye view. And then so I guess the spinous process, if we're bird's eye view, would be back here, spinous process. There's the other transverse process. Okay. The inferior, this one's important, inferior iliolumbar ligament. Now some people like Cramer doesn't mention a vertical. They're both going downward. Maybe he doesn't even, actually emailed him last night about that to see what he has to say, if anything, about that. But here's how Bogduk goes. In both chiropractic board books, right? So it's crazy when something like that happens. It makes it very tough for professors and teachers. Like, what do I teach you? Which way do I teach you? Since we don't know for sure which way a question is going to come. It could come from either book. So you got to know them both, I guess. Anyway, inferior iliolumbar ligament arises from the lower border of the L5 transverse process, and this one actually is so broad it actually connects to the body of L5 as well. No L4 here anywhere. Neither Cramer or Bogduk mentioned an L4 connection like all the pictures are drawn. It passes obliquely downward over the top of the anterior part of the upper part of the anterior sacroiliac ligament. And you can see those in cadaver specimens really easily. And it inserts into the iliac fossa. It's clinically significant because that's not right either. Well, it depends which board book you're going with. If you're going with Cramer, it makes up the lateral boundary of the L5 ventral rami. Sorry, this one's kind of messed up too. I got to go back and fix that. On your lecture slides, these will be fixed. So that should be ventral rami. And it calcifies, could be a source of radicular pain if you're going with Cramer. If you're going with Bogduk, it's those kind of vertical running fibers that do that. So I left that out there from trying to modify these slides again last night and built some new slides. And yep, that's what happens when the first lecture from fresh slides occur. So here's the star then. So these vertical iliolumbar ligaments, they arise from the anterior inferior border of L5 transverse process. They descend, vertically, straight down, and they connect with another region. I'm not sure if you know this. In fact, I know you don't know this. They connect with something called the arcuate line, and this should be definitely added to your osteology list. It's not in the gross anatomy manual, which should be added in there. Let's see, can I draw this? I didn't put a picture. I took some pictures, but they didn't come out very well. So let me try to draw this concept if I can. This is going to be tough for me to draw. But let's draw the superior pubic rami. There's both of them. This is the symphysis pubis in here. So this is a bird's eye view. This is the anterior. This is the posterior back here. So, and let's see, what color should I go with? How about red? Well, let me keep drawing this. So this goes back like this, and this is a superior pubic ramus. I forgot that I should have just put a picture in here. All right, here's my terrible drawing. Now let's go with red. Sorry, I forgot my water too this morning, so my throat's all messed up. All right, so there's some hills and lines and things like that. And this is always complicated for students. So this is how I teach it. There's a volcano right here, and that volcano is the pubic tubercle. Right? Pubic tubercle. It's right here. Now, off this, we have several lava flows. We have one lava flow going like this. Sometimes it's easy to see on real cadaver specimens or real bones. Sometimes it's not so easy to see, but it's important because rectus abdominis attaches in here, amongst other things. So this is the pubic crest. Pubic crest. Pubic tubercle is always lateral to the pubic crest. And then the lava also flows this way. on the inside of the superior pubic ramus here. This is called the pectineal line or the pecten pubis. Okay, I won't write that down there. Pectineal line or pecten pubis. It hits a bump right here. There's a distinct bump that you can see. That's called the iliopubic eminence, this bump, the iliopubic eminence. And then, let's see, what colors do I have left? There's another line running like this that goes to a familiar structure. This is the, do I have orange, I wonder? I do have orange. This is the auricular surface of the ilium. This is just a cartoon, right? To show you where this insertion is for the vertical iliolumbar ligaments. So it's actually ran out of colors, but it actually inserts. Do I have a purple, I wonder? No. Let's go back. It actually inserts right into here. I'll leave it orange. Oh, I have a pink. So that's where it inserts. And this is called the authors could have said it inserts into the arcuate line. Would have been better. But instead, they call this whole structure from the arcuate line all the way down here to the pecten pubis or the pectineal line. Collectively, they call that the iliopectineal line. Iliopectineal line. That's both in Bogduk and Cramer, so that's fair game for a board question. So you should add that to your anatomy notes, and they won't test you on it, but you need that for boards. All right, so everybody good with that? Let me make a note, too, on 23 to put picture in next time. All right. Now we have Cramer coming. This is Cramer's weighing in. So iliolumbar ligament, the way Cramer teaches it, and I like it. I like the way it's more simple, really. But there's two main parts. There's an inferior band and a superior band. And the inferior band, he doesn't say anything about a vertical iliolumbar ligament. So he just calls it the inferior band, aka lumbosacral ligament. Okay, so I don't know what to do. As I said, I emailed him, so I'm not sure which way to teach you guys. So I'll teach both ways to you. There's also a superior band, and that's cut into the anterior and posterior. But unfortunately, Bogduk says this band doesn't exist anymore. So you can see how frustrating it is for me, as well as these students, probably even more frustrating. So let's look at the iliolumbar ligament, the inferior band. So here's his inferior band, and he doesn't have the vertical band. Remember, we had a vertical band running down, right, from here. And that one goes all the way down to the arcuate line, which would be right up here. Here's the auricular surface, and the arcuate line would be coming about here. So that is the one that would be the hole, or make up part of the hole for the ventral rami of L5. But nevertheless, the way he teaches it is more in this drawing, where it's going from the transverse process in the vertebral body, and these are the inferior iliolumbar ligament, and then it's connecting in to the sacroiliac here. All right, so that's the way he teaches it. And therefore, if this was true, you would have, this would make up the lateral part of the tunnel for either the L5 ventral rami, or you can see over here, the L4 ventral rami comes and connects into the L5 ventral rami to make up the lumbosacral trunk beneath that. And we can see that in several cadaver specimens in our school. Sometimes it does occur up here. Sometimes that is the lumbosacral trunk. Sometimes it doesn't occur to way down here inside the pelvis. So it depends what what actually could get pinched in here. But the important part, one good thing about Cramer is he put this nice bit of clinical pathology, which I have heard of before. And did I not give it to you yet? I will in a second. Make sure I got everything there. All right. So it covers the L5 ventral rami, maybe the lumbosacral trunk, depending how the anatomy is. So big trouble if it calcifies and you get bone spurs stabbing the lumbosacral trunk coming out of there. Could cause radiculopathy. So here's the interesting, I have seen this on a cadaver before. And I've had a patient before who's had this anomalous structure. So in about 3%, there is an anomalous band that extends medially to the sacral promontory, to the lip of the sacrum. You're not supposed to have that. So now you're not supposed to have this, so the intervertebral, or this kind of foramen that it makes for L5 or the lumbosacral trunk is very narrow. And if this calcified, I had a patient who this calcified really tight and it was all jagged and it was irritating his nerve root here. And so it can entrap and irritate the lumbosacral trunk, depending on the anatomy again, and be a rare cause of L4 and or L5, I should have said L5 and or L4 radiculopathy and radicular pain. So that's clinically important, this inferior iliolumbar ligament, or the vertical ligament, depending on what source we're going to go with. So I'll have to be very careful when I make questions up about this, as should people making board questions for you, because of this kind of conflict between the two. Let's see. So there's a superior. Here's that thing I was trying to draw. This is the anterior. This is a bird's eye view of L5 vertebral body, pedicle. Be here. There's the transverse process, and you can see the anterior band comes off. Both of these come off. It doesn't show. So these anterior iliolumbar ligaments, they go the entire transverse process, the front of it, more like that. And then the posterior iliolumbar ligament comes more from the back side here. Sometimes there is a distinct cord coming off the tip of this one, but it all comes like this. Okay, runs from the medial lip, superior part of the crest, everything we talked about already. Blends in with quadratus lumborum. Bogduk says it is the quadratus lumborum aponeurosis, the superior one, right? We said Bogduk says it doesn't exist. So anyway, that's kind of the story there. Let's get away from that crazy ligament. But it's clinically important, so we have to know about it. Posterior sacroiliac ligament, there's no question that exists. There are two fibers. There's the long fibers of the posterior sacroiliac ligament, which we can see on the cadaver specimen quite nicely, and the short fibers of the posterior sacroiliac ligament. So let's talk about those two. The long fibers of this ligament first, they arise from the intermediate and lateral sacral crests. So we know our crests, we know our posterior sacrum quite well by now. They course superolaterally, so they move upward and insert into the posterior superior iliac spine, the inferior portion of it. Laterally, they actually blend in with the medial fibers of something called the sacrotuberous ligament. There's kind of a vertical running part of that, as we'll see. So let's look at this whole region. So here, you guys are very familiar with this, these kind of oblique fibers, right? So they run from the ischial-tuberosity, they run over to the sacrum, the lateral portion of the sacrum, but there's also fibers that go up, these vertical fibers. So this whole thing is the sacrotuberous ligament. Here's our cartoon of our long fibers of the posterior sacroiliac ligament run just like this into the PSIS here. But notice how they do connect laterally with the sacrotuberous ligament, specifically the superior or kind of vertical fibers of the sacrotuberous ligament. That's the story there. Several important structures are attached to this ligament, so it serves as an attachment point for gluteus maximus. Not the full muscle, but it has some fibers sinking into it. Gluteus maximus attaches everywhere. The deep fibers of the posterior thoracolumbar fascia attaches to many places. The aponeurosa of the erector spinae muscle, and the deep fascia of the sacral attachments of the caudomost multifidi muscles. What does it do? It helps limit something called counter nutation. Counter, that's an important concept. Nutational motion, we talked about that before and I wasn't able to show you, but I got a picture in here this time. So here is a posterior to anterior view of a cartoon of the sacrum and the sacroiliac joints. We kind of pushed them apart so we could show you that. Or there's the auricular surface of the sacrum. Can't see the auricular surface. It's made of the ilium, but it's there. And so if I, like a teeter-totter, the sacrum's like a teeter-totter. If we teeter-tot forward, if we put the child on the anterior end, like into the plane of the page here, the sacrum's going to tip forward. That's called counter-nutation. Counter-nutation. If we do the opposite, if we put the child here, and I draw the arrow, I guess I could have drawn it like this, coming backwards, it rotates backwards. I should have put a link. There's a video that you can actually see this on, the movement on. But I think you get the idea. So that's the concept of nutation and counter-nutation. Okay? And I'm sorry, I messed that up. So nutational is actually going forward. Yeah, I always remember forward nod. Forward nod. So moving forward is anterior is nutation. Moving backward is counter nutation. I've heard people call it anterior nutation and posterior nutation. But nutation is, this arrow is nutation. Okay, long fibers of sacroiliac joint, they prevent this counter nutational motion, this backwards nodding. Okay? Now the short fibers of the posterior sacroiliac ligament, they are also from the medial sacral crest, but they originate from the intermediate and lateral sacral crests of S1 and S2, not S3 and S4. These fibers are more horizontal. You can see them on the cadavers. And yeah, they're really short too compared to the long fibers of the sacroiliac ligament, hence their name. They insert into the medial lip of the iliac crest and the posterior iliac spine. Take a look at those in a second. Let's look at them right now. Here they are right here in yellow. Nice cartoon. They might go down a little bit further than this shows. All right. One of their functions, according to Bogduk, is they connect to the upper interosseous sacroiliac ligaments and give them some support. So they help bind the ilium to the sacrum. So they're more clinically important, perhaps, than the long fibers are. They also prevent something called a sacroiliac diaesthesis. Diaesthesis is a slip when two sections or two bones actually dislocate, if you will. And that's a diaesthesis. Diaesthesis of the pubic symphysis is common. If that happens, my daughter actually had this after her third kid, her third grandchild, number 7, I think it was. Wasn't so lucky for her. She actually had a diaesthesis of the SI joint and the pubic symphysis. So I can draw, I'm not too good at drawing this probably, but if we look at an A to P view, superior pubic ramus, this is A to P view. I guess these would curl more around like this. So normally we have some cartilage in here, right? I guess I can draw that a faint color. How about a yellow? So we have fibrocartilage in here, but when you're giving birth, the relaxin and other hormones kind of dissolve this. And she had not her usual OB/GYN doc came in and did some weird birthing position, and she had horrible pain for a long time. I think I told you her story before. but she got a diathesis. So what happened, you could see on her x-ray that this one, it slipped way forward and posteriorly like this. And her SI joints did the same thing. That's a diathesis. So I like that term, diathesis. All right. What else we got? Sacrotuberous ligament. It's got as we said already, oblique fibers and upper or vertical running fibers or superior running fibers. So let's look at these upper fibers. They rise from the lateral epithelial crest and the PSIS, just lateral from the long posterior sacroiliac ligaments. We already said that. And yep, the fibers are intermingled with that. Some fibers also rise from the posterior inferior iliac spine. Let's take a look at it again. So we're talking about right here. It's kind of origin is right here. So some of them go into the lateral iliac crest. This is the iliac crest, of course, here. There's the PSIS is right here. So we got kind of a broad origin. And then they course downward all the way down into the ischial-tuberosity. They also meet the oblique fibers. So they bind with the oblique fibers and they bind with the long posterior sacroiliac ligament as well. That'd be a good question. Which one of the following does not bind with the long fibers of the or superior fibers of the sacroiliac ligament? Because you think sacroilium, you think, so these long fibers really aren't connecting to the sacrum, are they? I mean, they're connecting through their connections with the long posterior sacroiliac ligament and the oblique fibers. So kind of a tricky little ligament there. Of course, the inferior blend with the oblique fibers, everything I just said. Okay, sacrotuberous. The oblique fibers now, these are the classical ones that you think of as the sacrum to the tube-ish tube, sacrotuberous ligament, rise from the lateral sacral crest, and the lateral margins of the lower sacrum, according to Standring. Some of them actually come from the coccyx as well. It wasn't confirmed by the other authors. And fibers move more inferior-laterally and converge with the upper fibers, as I just said. They form kind of a common sacrotuberous ligament right above the ischial-tuberosity. And they all insert medially into the ischial-tuberosity. So it's a complex ligament. Sacrospinous ligament, this one's pretty straightforward. It arises from bone bar or costal elements in the lateral masses of the anterior surface of the sacrum, S2, S3, and S4 sacral segments. It is triangular shaped, fairly thin, it's not super strong. Courses more horizontally, inserts into the sacral, from the sacrum to the ischial spine of the ischium. That's where that name comes from. Important about it, it helps form the greater and lesser sciatic foramen. And boy, you got to know what comes out of those structures. I just took slides out of this because I just don't have enough time to cover my stuff, but that should be covered in anatomy, gross anatomy. Make sure you know the structures that come out of that greater sciatic and lesser sciatic foramen. The job of this, it helps anchor the inferior sacrum to the ischium. Nice picture of it. There's the spine of the ischium, and there's our sacrospinous ligament. There is our greater sciatic foramen. Why is my laser pointer not back on? Hope I didn't lose you there. Yeah, that's never happened before, so I don't know what happened there. I don't have my backup copy running. I hope I didn't screw this up. All right, there it is anyway. There it is from the back. We're just about done anyway. Sacrotuberous ligament and the sacrospinous ligament function, so they help limit the already tiny bit of nutational and counter-nutational motion. And yeah, they tether the posterior sacrum to the pelvis. They help stabilize inferior aspect of the sacroiliac joint. All right, that's the end. Let's keep our fingers crossed this worked now.